Welcome to Symposium number 5, which we've called kind of aspirationally towards the development of a complete solution for patients with Alzheimer's disease. And we'll tell you what we're thinking about that. But first, let me tell you about who's going to speak and what we're going to talk about today. Mary Sano from Icahn School of Medicine at Mount Sinai will talk about self-detection of cognitive problems. Chris Van Dyke from Yale University School of Medicine, something about how emerging biomarkers are going to fit into this vision. And Dennis Selko from Harvard Medical School about moving toward combinations of therapies for disease modification in Alzheimer's. Just to set the stage, in the current state, we have over 100 therapeutic agents under clinical development for AD. Most of them are thought to be disease-modifying treatments, and at the same time, we're working on a host of complementary diagnostic tools and biomarkers that will do various things to identify pathology, help us to subgroup patients, and help us to characterize them in a way that might lead to the beginning of personalized health care. But there's more that needs to be done. We have to prepare the world for treatments. Regulators, payers, physicians, facilities that provide various types of treatment, enabling technologies that include digital biomarkers and drug delivery systems, standardization of everything so that if we use a biomarker, we can rely upon it. As we get one or more disease-modifying treatments in the field, and we expect that we will need to expand that research effort into earlier stages of disease and probably also into later stages of disease, and introduce new next-generation symptomatics diagnostics and monitoring tools. So the long-term vision is something like this. A person has a concern about themselves or someone close to them. They have a reliable self-assessment tool that they can use to check their subjective concern. They see a physician who has a number of tools that he or she can use that helps to classify, does this person have a problem? Do they have markers of risk? How bad is it? What's their stage? And then perhaps even a menu of possibilities of how that person might be treated. Once the physician and the patient decide how to treat, for how long, with what, there will be tools that say, okay, how's it going? Are we engaging our target, and how's it coming out? And do we need to try something else or add something in addition? And this vision extends to all patients, not just people at risk, not just people with prodromal disease, but if the patient somehow passes through those stages and comes to us with mild, moderate, or severe disease, really a total solution means that we should have something for them too. So we will begin then with a discussion of self-detection of cognitive problems, but look at, if we were to start this today, what are the challenges as well as the potential benefits? So Mary Sano.
Thank you, Rochelle. I have on this first slide my conflicts, and would like to begin by thanking you for having me here. Let me get right into this. I think I want to start by pointing out that self-detection of cognitive problems really is possible, and I want to talk about some sensitivity from measures of subjective cognitive impairment. I'm going to show you some population data that suggests, in fact, it's very old data, that suggests, in fact, we can detect very early before disease is confirmed clinically. In addition, we can see sensitivity in clinical trial populations of non-demented individuals at a very high level as well. There are some limitations, and we'll talk a little bit about age, education, and the cognitive stage. And then we'll ask the question, can we do better? Can we become more sensitive? Can we reach more people by using digital applications? So this first slide, a little difficult to read possibly, but was data from the Washington Heights aging project that has been going on for years. And if you look down here, you see this was published in '97. And the important aspect of this is it's a multicultural cohort, and education level is not particularly high. Here the mean age runs around 8 years, something that is often ignored when we talk about this sensitivity. We mostly think this is detection in a very highly educated population. What I want to show you is that when we ask the question of how's your memory and has it worsened in the past year, what we can see is that that positive response predicts increased risk of dementia. And while in the normal population, that increase, I'm not sure if I have a pointer here, do I? Yeah, is low, it actually is doubling the risk. And in those who have some evidence of cognitive impairment already, what you can see is it makes a massive difference. So in this next slide, we look at a cohort from the prevention instrument trial. This is an older cohort, and the cohort is much more highly educated. But what you can see is a separation on the cognitive function instrument, which is a set of self-administered questions about cognitive impairment, showing that at every point in time, those individuals who show cognitive decline have very early detection of their own likelihood of cognitive impairment and cognitive change. And even over the 4 years, that increases, despite the fact that we know that they're having an increase in cognitive decline, they're still able to detect that something is wrong. So these are just 2 studies I've presented, but this is a really hot topic, and some have denied that subjective cognitive impairment is really meaningful, and yet this meta-analysis from several years ago suggests a really doubling of risk in the presence of cognitive or memory impairment. So I think we've really come to realize this may be important. Most of this is done by interview or questionnaire. So can we do better online or with a smartphone? And this is what everyone is particularly enthusiastic about. But I think the first thing to ask ourselves is, do we have enough penetration of computer technology, digital connectivity, and smartphones? And I think it's important to go through some of this data and see what current patterns are. So what I'm showing you here is internet access in the first graph. The internet access is certainly related to age, and what you can see in this cohort of over 65, about 66%, or 2/3 of the population, have internet access. The second thing to think about is what is the access across the range of individuals in this older population. And I think this slide is also particularly important. Looking here, what you can see is that over 65, smartphone penetration is a little under 50%. And depending on how well-to-do, how accessible the population is, this number can be higher, but it is really sensitive to age, and we'll look at that more carefully. You can see that the availability of smartphones really gets reduced as you get into critical ages, 65, 70 to 74, etc. Equally sensitive to this penetration of technology is education, and what you can see is the level of education is highly reflected in whether or not a person has access to smartphone technology, and obviously income. And I think income's particularly important because it is a real risk as people age. Income levels go down, and the expectation of the penetration of technology can be at risk. However, I think it's important to realize that it's not impossible, and over time we can expect to see more technologies become available to a wider range of individuals. And I've broken down some of the other technologies that we think about today to again show you what we really have in terms of availability of these to aging populations. I think this data suggests that actually if we go as low as 50, and when we talk about early detection, maybe we really are talking about populations that young, smartphone penetration is relatively high, although again you can see it goes down by decade. But I think also important to see on this graph is, first of all, the older laptop, desktop, computer technologies are actually relatively high among the later decades. Most importantly is to notice that wearables and home assistant devices are very low. And these are the technologies that actually might help us with even greater access to data collected from individuals able to track their performance. So the next set of data I want to share with you is data from AARP, which suggests, which indicates what people actually do with these technologies. And so what we're looking at here is the range of activities from the lower range of activities. And what you'll notice is in this lower range of activities is really where you see most of your health-related activities. So we do see individuals getting health information, both on smartphones and online. And here you can see actually where smartphone use is lower. In addition, what you can see, and I think this is the one that I really want people to pay attention to, is tracking health or fitness with apps or on a website. This is relatively low. And this is the type of device that might actually bring us the greatest opportunity to self-detect. The next slide reminds us that when we look at, this is data from my own center, that penetration is even lower when we talk about the diversity of a population. And this is a small sample from our own local community in which we have, these are all English speakers taking the survey, but a wide range of diversity of backgrounds. And what you can see is that really nearly halves the access to these technologies. So what about when we do have the technologies? How likely are we to use them to monitor and to track? Well, what I'm showing you here is an experiment done in which individuals in the perhaps range that we care most about, these are individuals in their 50s who were at risk for dementia and willing to participate in this 6-month study in which they were asked to use mobile devices to track performance on a range of cognitive tests. And this is not performance, but what I'm showing you here is compliance and participation. And what we notice is that adherence is barely 60% across this kind of application. And this is from a highly motivated, highly selective population. So while we have a possibility here, you can see we have work to do to get people to consider using these most effectively. So now I'm going to turn to wind up to talk a little bit about some data that we have collected in a clinical trial that examined 3 types of technology. In our world, they may be considered quite old now, technologies that were installed in the home in elderly individuals to see if we could actually track cognition over time. The technology started at a low level with a mail-in set of questionnaires and an in-person telephone interview. Another was an interactive phone system, and the third was a computer system. We put a desktop in the home, and we set the home up with internet access and asked them to perform their cognitive and functional tests through this kind of technology. In this slide, I have sort of an overview of the it's a graphic that sort of describes the overall trial. We randomized individuals, over 500 individuals to this study at 28 sites. Individuals were randomized to one of those 3 technologies and to different frequencies of assessments as well. The assessments included a wide range of performance measures, cognitive, functional, a self-administered global, a behavioral task, quality of life, pharmacoeconomics. And individuals actually had a face-to-face evaluation, which was our gold standard of what was going on at the beginning and at the end of the study, and at any point at which we thought they changed. What I want to show you, first of all, is the overall flow of participants. What's particularly important to note is the relatively high dropout in the technology arms, the highest technology arm. And what's interesting is it was that capacity, that luck of the draw that they might actually get a computer installed in their home that engaged them in the study in the first place. But when the computer came in, there was a little bit less enthusiasm about having it there. So I think we have a ways to go. These differences in participation rates are actually statistically significant between all of the groups. The next slide. Okay. So I'm going to describe, this is a very large study with many outcomes. I'm going to really focus on just a few pieces of data in this next few slides. In this cohort, what we did was through our gold standard in-person evaluation, we identified a cohort that was stable and did not change, and a group that converted either from an early mild cognitive impairment onto dementia or from normal to MCI. And we determined whether or not the in-home assessments could actually predict that change. In particular, in this next couple of slides, I'm going to talk to you about a memory composite that we collected in these in-home assessments. It's summarized, delayed, and an immediate recall in both a word list and a paragraph test. And I'm going to be showing you some data that examine the change scores and the ability to detect change in between these stable and converting groups. What's the earliest point in time, and how frequently or how infrequently did we have to assess to get that change detected? Just a quick minute to look at the sample. The over 500 patients had a mean age of 81 and were relatively highly educated, but we had great diversity with 22% being non-white, being non-white Hispanic. The population had what you would expect in terms of cardiovascular disease and hypertension, which is pretty common in this age group. So in this first graphic, I want to show you what the data will be looking like. The top line is the change score in the converting group, the red line. The blue line is the change score from baseline in the stable group. And the bottom graph shows you the delta between those changes. At any point of asterisk is the point at which we can first detect a significant difference between those groups. And what you're seeing here is when we look across all time points, including all of our individuals together, we were able to detect at about 12 months. That was the most common when we summarize all the data. But when we break it out and look at the specific arms and the frequency, this data is from the kiosk or the computerized arm, and what you see is that when individuals were assessed quarterly, we had pretty early detection of differences at 9 months. However, when we thought we could get an even earlier detection by assessing monthly, we really didn't see a change until the end. And most of this is driven by a practice effect. So over-testing can be a limitation as well. I think I want to wind up here and just sort of tell you about what I think we can think about as we go forward trying to develop better methods of self-detection. I think we know that self-detection of cognitive change is really possible, both with subjective questions as well as with cognitive assessments that are more objective. Digital technologies, including both the smartphone and these computer adaptations, really do have the capacity to collect objective change, but there's some challenges, and those challenges include the availability of the technology in groups that we really care about assessing, groups defined by age, education, income, and by their diversity. I think the motivation to do routine or frequent assessment is also a challenge. It may be difficult to get people to maintain that. Practice effect of over-assessment or standardized assessment can be also a risk to hide a change that may be beginning. And I think despite this, there's a really great opportunity in these mobile devices. I think the penetration of the smartphone really is a place to go. That's something that we can expect to see possibly more and more individuals have, and now the challenge is to make them, to help them learn how to use it. I think we have to optimize the modalities, both in terms of the frequency at which we assess and age-specific preferences for which type of modalities. And finally, I think we really have to consider the possibility of adding subjective impairment via these digital assessments, creating more ecologically sound measures of assessment of self-assessment of cognition. And I'm going to end there. Thank you.
Thank you. We are really trying hard to stay on time so that we'll have time for discussion at the end. So I invite Chris Van Dyke to the podium to put his view about today's reality and the potential for biomarkers.
So thank you, Rochelle, and I want to thank the organizers for including this symposium. As you can see, I think I've tweaked my title. Let me just see here. How did I get here?
Isn't the same presentation, is it?
No. In any case, I've tweaked my title a bit from what's in the program. I am going to talk about early diagnosis with regard to plasma A-beta biomarkers, but then I'm going to include a biomarker with CSF and one with PET, which pertain more to the topic of looking at disease progression.
But you had one presentation for all of you or not? No, because I think it's all here. You had all the slides on one presentation.
Yeah, I think you're right. Yeah, I'm sorry.
No, we just had to. We just have to go over all the slides and then we get to yours.
Okay, good. Thank you very much, and sorry about that. So here's my disclosure. And the first topic, plasma A-beta biomarkers, I kind of think this has already been touched on at this meeting. In fact, by the people who have done all the seminal work. So what I'm going to do actually is summarize the results from 3 of the now somewhat established assays and talk about their use in a future trial. So I think we'd all agree that there's a pressing need for plasma biomarkers of dysregulated amyloid metabolism, both for screening for trials as well as for ultimately for diagnosis. Amyloid PET is expensive. CSF measurement, some would say, is a tad too invasive. And conventional ELISA-based techniques to assess plasma levels have thus far proven unsuccessful. In the last year and a half, there's just been a whole series of developments in this field which have really advanced it. So just by way of review, last year's AAIC meeting now well known to most of you. Bateman and colleagues at Washington University presented their data with their immunoprecipitation mass spec assay. And they showed that a plasma ratio of A beta 42 to 40 was significantly reduced in individuals who were amyloid positive, as determined by either PET or CSF, relative to those who were amyloid negative. And moreover, there was enough group separation that the ROC analyses shown on the right provided a very impressive area under curve in the order of 89%. So those data were followed fairly soon by data from a Japanese-Australian collaboration with a similar IP mass spec assay in now larger samples, and they demonstrated that a similar A beta 40 to 42, the inverse ratio, again showed very good group separation. And they also looked at a ratio of a particular APP fragment to A beta 42 in the left panel, and similar results with that. And their best biomarker of all was actually a composite of those two, which was an average Z-score of the marker shown in the left and center panels. So their ROC, corresponding ROC analyses, again demonstrated very good results with all three of those parameters. So to touch on first of all, the A beta 40 to 42, which is more similar to the WashU ratio, that's shown in blue in each of these panels, and showed a area under curve in both the discovery group. I should mention that they did look at both a discovery sample, Japanese sample, as well as a validation sample from the Australian ABLE cohort. So they found very good areas under curve for the discovery sample, as well as validation samples from Australia. And the two different validation samples, on the far right is the overall ABLE sample confirmed by PET, and the middle panel is those who were homogeneously confirmed by particularly PIB-PET, so the cleanest validation sample. So again, areas under curve and validation were 89 and 84%. And their best measure of all, the composite, showed 97% in discovery and 94 and 88% in validation, respectively. So very impressive data for these mass spec assays. But of course, and these are probably already for prime time, I would think, in terms of clinical trials, but not so much for clinical care, where we need a higher throughput assay, an immuno-based assay. And so at this year's AAIC meeting, 2018, Hansen and colleagues presented still more exciting data with the Roche Alexis assay. This time in still larger sample. This was 843 cases altogether, Swedish participants who were analyzed both with CSF and blood, with the Alexis assay. And you can see, if we just sort of focus on the right, that again there was very good group separation between the A beta positives and A beta negatives, and these were individuals spanning a diagnostic range all the way from cognitively normal to mild dementia. I should point out that that was also true for the WashU subjects and the Japanese and Australian subjects as well, spanning normal to mild dementia. And again, that separation under ROC analysis performed quite well. So if we first just look at the more similar, A beta 42-40 ratio to the other assays shown in green, there was an area under curve of 80%. But that could be augmented by adding additional information. So for example, if you add the ApoE genotype of the individual, now we have the purple curve, and we get the area under curve up to 85%. So really, really quite impressive, and just a series of of very exciting developments. So where do we go from here? Well, obviously, the people developing these assays continue to improve them. But for those of us who are already, to apply them, I think the steps are now going to be field testing, multi-center field testing, comparative testing, and appropriately, the ATRI, led by Paul Azen, I think most of you are familiar with the trackpad study that is going to be launched soon, and that'll be presented tomorrow at 1:30 p.m. by Gus Jimenez for ATRI, so please do attend. The trackpad study is going to incorporate, is planning to incorporate all three of these now semi-established assays in the multi-center trial. So this will be a great opportunity to field test and comparative test them. So the second topic, now the CSF biomarker, the holy grail of CSF oligomer assay. Now you might wonder why the next speaker isn't presenting this. Well, it's not Dennis's topic today, but I am going to present a bit of Dennis's work. I think we'd all agree that oligomeric forms of A-beta are believed to be principally responsible for neurotoxicity, at least many of us would. Sensitive assays for CSF, though, have been difficult to establish. But as we'll see, these assays now appear poised to establish target engagement and surrogate outcomes for developing therapies. So the assay in question was first published by the Selco lab and the Dominic Walsh lab in 2015, and notably very ultra-sensitive, had a lower limit of quantification for synthetic oligomers of about 150 femtograms per milliliter, and also 30,000-fold greater sensitivity for oligomers over monomers. And at this year's AAIC meeting, Dennis presented some data applying this assay now to the crenezumab monoclonal antibody phase 2 studies. So CSF collected from the Abbey and Blaze studies at baseline in week 69 were analyzed with this particular assay. And what you can see is that the actively treated patients who could have been treated either subcutaneously or intravenously in the middle and right panels, showed consistent reduction in oligomer levels from baseline to week 69. So in particular, for subcutaneous, there was an 89% of them showed reductions. For IV, 86% showed reductions, whereas placebo was kind of a wash as expected. And when you look at median change, it was about 48% for sub-Q, 43% for IV, and again, placebo, kind of a wash. So, very exciting. And I think that this kind of assay in the near term is probably going to be used in just this manner. And hopefully also looking at even earlier phase studies that are shorter term to establish target engagement with relatively small numbers of participants. How often do we need that, initial study to establish target engagement that we don't have? So I think that's, how we will see this assay used in the near term. So third topic is going to be an emerging PET biomarker, and I'll finally present something that I'm directly involved in, which is synaptic PET imaging. So I think that this audience doesn't need to be told that synaptic loss is important in Alzheimer's, the major structural correlate of cognitive impairment in the disease, and so the ability to measure it in vivo during a trial or in monitoring patients longitudinally, would really be crucial. Currently, we tend to use FDG PET, which is a measure of synaptic activity, and we use that to track progression and sometimes in trials as an outcome, as I showed yesterday, for example. However, FDG PET is not a direct marker of synaptic density and may be affected by things like stimulation, cognitive state, medication, blood glucose levels. So PET tracers are really needed for new molecular targets to monitor density. So enter SV2 and SV2A. So this is one possible target. SV2, synaptic vesicle glycoprotein 2, is an essential component of synaptic vesicles located in presynaptic terminals. Has 3 isoforms, A, B, and C, and it's the SV2A that is ubiquitously expressed in virtually all synapses. So a radioligand for this site might prove useful to measure synaptic density. And the Yale PET Center, led by Richard Carson, my colleague, recently developed UCBJ with the help of UCB Pharma, who provided the precursor for quantitative SV2A PET imaging. So what do we expect to see when we use this tracer in Alzheimer's disease? Well, we've really been focusing on fairly early disease so far, and based on the evidence for the early degeneration of entorhinal cortical cells, neurofibrillary change in entorhinal cortex, projecting to hippocampus via the perforant pathway, we expect to see primarily reductions in hippocampus, at with a presynaptic marker at the terminals of these perforant pathway neurons. And indeed, representative PET images from individuals who are, the top row is cognitively normal, the middle is MCI, and the third is mild AD dementia. You can see that the pattern of uptake for this tracer is really similar to FDG, especially in the normal. It maps with gray matter, of course. But from the white arrows, you can also see that there are reductions in the MCI person and the Alzheimer's dementia person in medial temporal lobe, hippocampus, including hippocampus. What about quantitation? So if we look at samples of, in this case, 11 normals and 10 individuals with AD, these were half mild dementia, half MCI, all PIB positive. What we see is that there are significant reductions in a binding potential measure with this tracer to the tune of about 41%. And one of the questions that always comes up is, well, are we just measuring tissue loss? Because these are hippocampus and some of the other structures we see reductions in are heavily atrophied. And I think in part that's true. I don't think it's the whole story. And when, for example, if we do correct for atrophy progressively with gray matter masking in the middle panel and then full partial volume correction on the right, the differences in hippocampal binding persist. I would say about half of the effect is washed out by atrophy correction, or does not withstand that, but about half of it does. And I think this fits the notion that in addition to tissue loss, there is a selective loss of these perforant path terminals coming from entorhinal to hippocampus. So, and this is all as published in our July JAMA Neurology article. But where are we going from here? What's next? Well, there are 3 things that we're in the progress of doing now. One is to look at the relationship to other biomarkers, and we're especially interested in tau PET, of course. For example, tau PET in entorhinal compared to SV2A in hippocampus. We're also going preclinically. We want to see what the earliest emergence of this signal is. So we're starting to look at, family and ApoE4 enriched samples, preclinical population. And the last thing is we're already applying this to drug studies, using it as an outcome measure, especially with therapies that are targeting synaptic function. And so we currently have an NIH-funded collaboration with Cognition Therapeutics to look at their drug, and others are planned as well. So in conclusion, there are several emerging AD biomarkers that hold promise for early detection and monitoring of disease progression and therapeutic response. With regard to plasma A-beta biomarkers, they've advanced and may already serve as screening tools for trials and ultimately, we hope, for clinical diagnosis. especially with a high-throughput immunoassay. CSF assays for oligomers appear poised to establish target engagement and serve as biomarker outcomes for developing therapies. And finally, SV2 PET imaging may provide the first in vivo measure of synaptic density as an outcome measure for trials, particularly those that target the preservation and restoration of synapses. And I thank you for your attention.
Thank you, Chris. Dennis is on his way up.
Good morning. Many thanks to Rochelle and her colleagues and to the CTAD organizers for enabling this symposium and allowing me to share some of my own views. I really only have one principal conflict or disclosure to make, and that is about the fact that I'm a founding director and consultant to Prothena Biosciences, but that has nothing to do with the content of my talk today. So the topic that I was asked to speak about is one that I think everyone in the audience is already committed to. I think there is little doubt that this complex disease will be treated with multiple therapies, and there's going to be indeed a discussion of that in great detail later today and tomorrow, and has already been at this meeting. So I will touch on that at the end of my talk, but I'm going to talk about my sense, as no one would be surprised from the basic science lab, on how we get to these multiple therapies and what they might turn out to be. And so in terms of therapeutic insights from the basic science of AD that's been so intensively studied over the last 3 decades, I will emphasize soluble A-beta oligomers as a key target, both for single and combination disease-modifying therapies. And I think we need to determine whether therapeutic agents target those or not, because I think there's more and more evidence that they are bioactive in vivo, especially small diffusible oligomers. So some of the evidence that supports that notion comes from reductionist experiments in which endogenous A-beta monomers and dimers can be isolated by size exclusion chromatography from saline extracts of AD cortex. And one of the things my colleagues and I have favored is to eschew the use of synthetic assemblies and recombinant protein, but go to the actual natural source. And you can see here that AD brain saline extracts have dimers of 8 kilodalton that can be separated quite cleanly into fractions with A-beta Western blotting, and they have monomers as well that are rich. And control brains of the same age, a woman of the same age as this patient, and these are sometimes patients I've followed during life, did not have this, and these are background bands. So if you apply fractions 8 and 9 that are dimer-rich, but not exclusively dimers, they're not pure, they are also oligomers that are in equilibrium with dimers, or you apply fractions 10 and 11, you can see striking changes in rat neurons or in human neurons. So in this example, rat neurons look quite healthy when they're not treated in vitro, and if they're treated with control brain fractions 10 and 11 or fraction 8 and 9, they remain morphologically healthy. And if they're treated with A-beta monomers, which provide an excellent control for the experiment, they come from the same patient's brain, from the same biochemical experiment, they do not impair neuronal form nor function in LTP assays. But dimer-rich extracts that have higher oligomers as well impair neuritic architecture and cause a beaded dystrophic neurite that we would liken to the dystrophic neurites that surround A-beta deposits, and the work from Brad Hyman showing there are diffusible oligomers going out from the plaque border. So there is a neuritic dystrophy that occurs specifically from A-beta dimer-rich human brain extracts. Furthermore, in lanes 4 and 6 of this Western blot, you can see that the application of the saline extract from the patient's brain elevates the abundance of the AT8 phospho-tau epitope, which has been used widely and which Leonard Mookie referred to in his very nice plenary on tau. And if you immunodeplete the A-beta oligomers selectively with an antibody that Dominic Walsh developed that takes out oligomers but not monomers, it's the one that's used for capture in the oligomer lysa that Chris referred to, then you no longer have an elevation of AT8 phospho-tau epitope. This does not say that phospho-tau per se is a crucial pathogenic modification, but it's one that we recognize in the disease, and A-beta oligomers from human brain can do this. If in these rat neurons you express human tau, you heighten this effect. So you can use lower amounts of the oligomers and you get more rapid responses. So human tau is more sensitive than the endogenous rat tau. Now, this type of approach has been used by us recently, taking advantage of the IncuSight technology from Essen, in which you can do live cell imaging in an incubator that has a video microscope mounted in the top of the incubator. And you can put in various flasks, most importantly 96-well plates, and you can culture human neurons. So this is an entirely human analytical system where we apply human saline extracts that have been partially purified and their immunodepleted derivatives to get rid of the A-beta oligomers, and we apply them to human neurons. These are neurogenin-induced human neurons from iPSC cells using the Sudoff protocol. And as an example, applying saline extracts of AD cortex to these human neurons, you can see a time-dependent loss of neurite integrity. The neurite length and neurite branch points are reduced, and that's best seen in the central panels, from 0 to 72 hours of real-time incubation of a 1-to-4 extract, 1-to-4 dilution of an extract from a typical Alzheimer brain. One needs to do this from multiple brains because not all Alzheimer brains have similar bioactivity, and then try to quantify the effects. If we immunodeplete with an A-beta oligomer antibody, 1C22, one can now, over 72 hours, see protection of neurite integrity. So no longer is there a loss of neurites. And that can be quantified. In the lowest curve, in red, is the extract from an Alzheimer patient directly applied, and then in the different colors are a dose-dependent rescue of the oligomer effect on neurites, on neurite length, using bapineuzumab as an example. We can obtain this nowadays commercially, and everyone can use it as a control. It doesn't come from a particular company. And this is an example of an antibody that shows a dose-dependent rescue when co-administered with the A-beta oligomer-rich extract. So from this, my colleague Ming Jin was able to get quite precise effective concentrations 50, here 1.1 nanogram per ml of bapineuzumab under our conditions, that can dose-dependently neutralize the effects of A-beta oligomers on human neurons in this all-human assay system. And this has been done iteratively, and so I won't deconvolute this slide. There wouldn't be time to do that, but we've taken a number of the antibodies that are now in clinical trials and others that may be poised to go into clinical trials. One that doesn't work here in protecting, so high is good, and this one is Avastin, which is used for macular degeneration as a control. All of this is done blinded and in a dose-dependent fashion with small error bars, and you can decide which antibody you think is particularly good at neutralizing. This is the medium alone. This is the AD saline extract rich in oligomers, and these are various antibodies tested to try to bring up the signal and neutralize. And this can be done for neurite length and for branch points as well. And cell bodies are not impaired, so you can use apoptotic markers, and the cells are not dying by any means, and indeed this is time dependent, so you can rescue this even if you remove and change the oligomer-rich medium off the cells at a certain time. Now, all of that recommends oligomers as one of the targets we could examine in combining disease-modifying treatments in the future. So the concept, obviously, is across the trajectory of Alzheimer's that we've discussed so much at this meeting. One could use monotherapies, such as anti-A-beta or anti-tau approaches, both of which I favor strongly, or more likely, ultimately end with combinations. So one could simultaneously target A-beta and tau pathways, or one could choose two different approaches to A-beta. And this is a concept that I think virtually everyone in the room already feels quite comfortable with and expects to happen. So where is the guidance to our field for using this approach? It comes, for example, from the American College of Rheumatology, which has published guidelines for treating rheumatoid arthritis with a variety of agents. So they wanted to develop evidence-based pharmacological treatment guidelines, and they created these guidelines through consensus to cover the use of traditional disease-modifying anti-rheumatic drugs, which are well known in the field, biological agents, glucocorticoids, and other emerging agents. And they address also in these guidelines the use of vaccines. And it includes 74 recommendations, 23% of which they classify as strong recommendations to their colleagues in the clinical community, and 77% conditional. And this, of course, is the kind of thing we would hope would happen in our own field. The conclusion from this study of creating these guidelines is that the guidelines should serve as a tool for clinicians and patients, their target audiences, but that these recommendations are not prescriptive and should not be used to limit or deny access to therapy. I suspect that we all would agree that we're quite a ways away from achieving this in our field, but I'll end with 2 slides that give my sense, my opinions, about how this will come together for our field, perhaps in the next 7 to 10 years. So I think many of us believe that there will be risk assessment at midlife, perhaps even earlier, depending on how non-invasive and sophisticated our methods are. As always in clinical medicine, history, emphasizing family history, will be important as we assess healthy people and a neurological exam. A cognitive screen will be performed more and more widely, and as Mary pointed out, this might turn out to be an e-screen on a mobile device, probably a phone, followed by neuropsychological testing to get more clarity about that. A gene screen will ultimately be offered. This can already be done, of course, but once there's a disease-modifying therapeutic, we'll be ethically more comfortable with advising our subjects to have a testing for genetic factors, and that will not just be an AD risk chip, but will include other familial dementias. Longitudinal plasma A-beta 42 to 40 to tau ratios measured, I said arbitrarily, over 6 to 12 years, perhaps longer, could be highly useful. And my colleague Dominic Walsh and his colleagues have a paper in Press in Alzheimer's and Dementia that shows a new fragment of tau, what they call NT1, measurable in plasma, that very nicely discriminates with a ROC statistic of approximately 0.88. So we'll see that data, and it can now be combined with the emerging data on 42 to 40. And we'll assess these rates of change in quartiles to see which subjects are most vulnerable. Imaging, of course, is going to continue to be a major feature, and we're now in the age of PET scanning for plaques and tau PET scanning for fibrillar tau, as we heard just before. I'd love to see an oligomer ligand come on the market that would distinguish plaques from oligomers. FDG PET remains a functional readout, and as Chris highlighted, SV2A PET and other synaptic tracers. And CSF assays will still be done and are very powerful, of course, despite the fact that they're invasive. The goal will be a numerical AD risk score, and that will lead to a way that we will manage the disease based on the risk category into which a person falls. So early pre-symptomatic subjects may be in their 50s and 60s, maybe even earlier on occasion, with borderline A-beta buildup, and A-beta scan includes the possibility of oligomer detection, will be offered a gamma secretase modulator or a low-dose beta secretase inhibitor. Based on what we've heard here too, that might be quite useful. I still believe that there is a role, an important role for beta secretase inhibition. But I think this is underexplored. We need agents that really work, that have good potency and brain penetration. This is a very attractive target from the basic science point of view. Pre-symptomatic subjects with clearly abnormal A-beta scans would be offered a gamma secretase modulator again, or low-dose beta secretase inhibitor, presumably one or the other, and some type of A-beta oligomer neutralizer. One that was tested in the past and rejected was scaloinositol, but it actually does neutralize the binding of oligomers to neurons very effectively. And of course, subjects who have abnormal scans would have an A-beta active vaccine, ultimately preferably, or passive antibody therapy to clear that amyloid. And our symptomatic subjects, of which there'll be a great many, who have abnormal A-beta or amyloid scans, will also be offered secretase modulators and an A-beta active vaccine or passive antibody therapy, and of course symptomatic agents. So to conclude, Like other chronic multifactorial diseases, such as RA and hypertension, AD may often be treated in the future with a combination of two disease-modifying agents that target the same or different pathogenic factors, and very likely 3 or more in the more distant future. In my view, this would best be accomplished by starting one agent with proven therapeutic or preventative benefit at a specified dose, and then adding the second agent. It'll be more challenging to prove the efficacy and safety of 2 agents given simultaneously. Because small diffusible A-beta oligomers increasingly appear to be pathogenic, as I've tried to exemplify today, at least one of the 2 agents should neutralize and or clear these, and that would very likely be an anti-OA-beta antibody or a compound, a small molecule that can do that, or both. And the second drug may well be an anti-tau agent. I agree with Leonard that this is an enormously important target, and that A-beta may operate via altering tau, among other downstream targets. And another anti-A-beta agent by a different mechanism would also be interesting. I again highlight a gamma secretase modulator. Thank you.
So we got a late start, so we'll take just about 5 minutes and not any longer than that. First, is there any question from the audience that you would like to ask? And with the movement in the crowd, it's hard to see, so I'm going to just go ahead and ask each person a question, unless there is an additional question. I see a hand. Yes, you get to be first.
Gregory Penner, neo-neuro from Paris. Great talks, great session. I would challenge the panel to even think beyond this, though, as AD as a gradient among other things. And when we think about biomarkers, when we think about everything, by 2025, let's think about measuring everything in people's blood and looking at everybody as individuals within a gradient. And welcome comments on that.
So any comment to the expansion of the vision there?
So the question, I didn't quite catch it, but it was about...
I think that, the challenge is just to go beyond even the things we're thinking about measuring now, to a vision in which everybody is profiled, I think, to personalize their care.
Sure. So my guess is that with what's coming on, especially the excitement around plasma markers, and it goes beyond tau and A-beta and a number of others, and neurofilament light is an indicator of... So I think we will be profiling people individually for their specific complementation of different markers and correlate that with their family history and their genetic risk, and it will be very much a personalized medicine approach.
And I think, I don't know if you're aware, there's also something we're working on at Roche, the Neuro Toolkit, which would be an Alexis-based, assay of 20 plus analytes that might even be applied across neurodegenerative diseases. So, yes.
Hi, Michael Ropacki. The great talks. A quick question for Mary, and this is a similar question that I asked Lon last week at the ISCTM meeting, which was focused on technology. And that is, when we talk about new technology implementation into clinical trials, taking something that is consumer-facing and validating it for use as a digital drug development tool, we set very high bars for the type of psychometric validation and other things that need to go on before companies or sponsors are willing to try it. And the point that I made is, why is this when, if you look at the majority of the prevention trials that are ongoing or have failed, they use the older neuropsychological measures in a way that they were not properly validated, in that they don't use them in a way that there are norms available, and they were designed to be used as an entire battery, but they pick and choose pieces out. Why is it that the old tools get a pass, but the new tools are held to such a high standard?
So I think you highlight a really important issue. Each one of these tools has been validated many have been validated in smaller populations, and then they're used more broadly. I guess my comment would be that the breadth of use of an old tool actually gives us a great bank of information against which to measure current performance. And so while they may not have been formally validated before use, their high use in large populations really gives us a knowledge about how they perform. That being said, it doesn't have to be the one that comes into technology, as long as technology can compare against some gold standard, or a new tool can compare against some gold standard. I do agree.
Thank you.
So.
One question for Chris, and then we're going to close. Chris, I'm really interested in your synaptic SV2A PET imaging marker. When you corrected for the volume loss, you lost about 50% of the power to separate between the groups, cases and controls. What are you thinking about that? How are you going to get it back up? You know, what are your thoughts?
Well, I actually think that was, I'm very optimistic about that. I mean, that so often in Alzheimer's disease, when you partial volume correct, you lose your finding completely, as you know, many of you know. So the fact that in hippocampus, you know, kind of per the hypothesis, it isn't completely washed out, it does withstand that, I think is important. I mean, interestingly, it isn't always the case. So I didn't show data with other structures. Entorhinal cortex also shows substantial group differences, but when you partial volume correct there, the effect is completely lost. So I think there, when we are measuring with SV2A PET, we are probably imaging tissue loss. And that does fit with the fact that, you know, again, entorhinal isn't so much a place where, you know, the terminals are being lost. You know, it's where cell death, you know, is occurring.
So you think it's still going to have enough power to differentiate and be used maybe as a diagnostic tool?
I don't personally see SV2A PET as a diagnostic tool. I actually suspect there are things that are more sensitive early. I think it's much better as I think it has much more potential for tracking progression and as a therapeutic outcome.
Okay, great. I'm going to, unless it's super quick, I'm going to ask you to.
It might be.
Okay, try.
Yeah, this is Fernando Goñi from NYU. It's one of the things that it doesn't matter if it is A beta, this tau, or any other one, amylin, alpha-synuclein, whatever. Unless you change the conformation to a beta sheet dominant, you are never going to have a disease or a problem. So how can we attack that instead of attacking the downstream effect that we are having and not preventing the molecules that could be either the peptides or the proteins to change that conformation?
Yeah. Do you want to?
So if I understood it correctly, the conformation of these proteins are critical for their bioactivity, and I'm not sure that we have good molecules that would change the conformation in vivo in a safe manner. And so I think what you've heard this morning, including about tau from Leonard Mucke, is to reduce the total levels of the native species prior to its conformational transition. So decreasing tau, for example, by ASO strategies, or clearing A beta oligomers in a wholesale fashion with some of the antibodies that we're studying. I do agree that once conformation is changed, that material will likely be stable and bioactive. And so we need to get far upstream of that by decreasing the precursor that causes the abnormal conformation.
Yeah. So I don't know about the audience, but I'm beginning to feel a difference for the future of managing Alzheimer's disease. And I think that we've made a few steps in that direction, as very beautifully summarized by all of you. So thank you for your presentations. Thank you for your attention. Enjoy your lunch.
Pressure, pressure, I've found pressure, pressure, I've found